Hi, everyone. Thank you so much for attending this DEX poster presentation titled Addressing the Needs of Persons with Upper Limb Absence Through a Multifaceted Approach. Myself, Maura Pitluck, along with Alison Johnson, Sarah Kelly, Sam Pagano, and Mcavee Gabay, have worked under the advisement of Dr. Latour to complete our capstone. The overall purpose of our project is to address the unmet needs of persons with upper limb absence to promote occupational performance, participation, and quality of life. As a population, persons with upper limb absence have unique yet unmet needs. Many are at increased risk for secondary physical and psychosocial conditions. However, there are limited resources available to get these needs met. Virtual services and virtual platforms can bridge gaps in care by overcoming geographic barriers to connect people. As a DEX group, we used a multifaceted approach to address these unmet needs. Collaboratively, we connected members of the upper limb absence community through the expansion of the Unlimited Wellness Program. We also developed a workspace appropriate for teleconferencing in the basement of an existing building on Western New England's campus. Our independent projects extended this group vision. For my project, I investigated the healthcare inequities faced by persons with upper limb absence, focusing on prostheses procurement and access to quality rehabilitative care. I used the PEOP model to guide my thinking, applied it to a population perspective, and identified ways in which OT practitioners can advocate. I wrote an article on this topic, and I am intending to submit this to the Journal of Prosthetics and Orthotics for consideration.
My name is Alison Johnson, and as an individual component of this DEX, I worked in collaboration with Diane Atkins, an occupational therapist and well-known upper limb absence researcher, to develop a new research project titled Experiences and Outcomes of Individuals with Partial Hand Loss. This research examines the psychological adjustment and return to work outcomes for the partial hand loss population. The focus of this project during the DEX was on designing and implementing the mechanics of research, including survey design, subject recruitment, IRB approval, and data collection. The scope of this project extends beyond the DEX timeline. We are currently still in the data collection phase. However, I was able to report on some encouraging preliminary results during my DEX portfolio review. This fall, I will continue to work with Diane to do more in-depth statistical analyses, and it is our hope and plan to publish our results and present at a professional conference within the next year.
My name is Sarah Kelly, and as a group, we transformed the basement of the Bellamy House into the Occupational Therapy Wellness House. Now there is an area where telehealth can be completed. The space currently has a conference table with chairs, 5 desks with chairs, and a smart television equipped with a video camera. This area has potential to be used for telehealth in the future, not only with occupational therapy students, but also through interprofessional practice with other disciplines. Individually, I worked on determining the feasibility of using this space as a Level 1 telehealth fieldwork site for future Doctor of Occupational Therapy students. In order to assess this, I completed a needs assessment and literature review, which led to the development of a survey for the class of 2021 to participate in. Based on the results of this survey, a report was created which will be given to the Department of Occupational Therapy to explore future program development options.
My name is Samantha Pagano, and as an individual component of this DEX, I created and implemented an additional unlimited wellness module discussing intimate relationships across the lifespan. The creation of this module included a literature review discussing the psychosocial factors that influence intimate relationships in individuals with upper limb absence, and the development of a schematic diagram depicting how intimate relationships develop over time and the internal and external factors that influence them. I plan to share this schematic with a wider population so that it can be used with other diagnoses and conditions.
My name is Mcavee Gabay, and my project consisted of working with HandSmart. I got involved working with HandSmart, which is a group of international clinicians focusing on upper limb absence rehabilitation. I am currently proposing a global expansion of a virtual support group to HandSmart by trying to expand the Unlimited Wellness Program and link the upper limb absence population worldwide, and further bring more traffic to HandSmart and find partnering organizations to generate revenue. Moving on to our program, Unlimited Wellness, which was developed by Dr. Deborah Latour, is a program designed to link individuals with upper limb absences as peers. Dr. Latour used telehealth to address the unmet needs of adults with upper limb absence through this program. The Unlimited Wellness program successfully used telehealth to meet the specific needs of individuals with upper limb absences to better their quality of life and empower them. Our main goal for this project was to expand the Unlimited Wellness and provide services in a 1-hour weekly virtual group that ran for 8 weeks. The goal of Unlimited Wellness was to promote health and well-being through community support and engagement. It was designed to empower and educate group members to improve their quality of life. Part of the program planning was to develop research questions to identify the population. The research questions that we developed are: is the Unlimited Wellness Program expansion effective for adults with upper limb absences of varying ages and level of absences? Does a virtual support program increase knowledge on secondary physical and psychosocial condition management for individuals with upper limb absences? Our population is adults with upper limb absence above the ages of 18 and parents/guardians of children with upper limb absences.
The Unlimited Wellness Program was held over a 5-week period where one session occurred weekly pertaining to a different topic. Participants were recruited to participate through Handspring Clinical Services. By email, individuals were invited to participate in the Unlimited Wellness Program and take a pre-program survey. The first 2 sessions were about overuse injuries, and the topics for the following 3 weeks included preparing for a medical consult, awkward social situations, and intimate relationships. In order to prepare, as a group, we created weekly group protocols and tip sheets to guide the session. Tip sheets were filled in during the session by group members who were observers. In order to communicate with participants, the 5 students created messages to be sent. Dr. Latour would review the messages, and finally the messages were sent on her laptop. Dr. Latour's laptop is connected with Handspring Clinical Services and is HIPAA compliant. Ongoing communication with participants occurred through email, Instagram posts, and weekly feedback surveys. The final products for the Unlimited Wellness Program included finalized tip sheets and a resource guide. The resource guide included information on adaptive equipment recommendations, general resources, exercises and stretches, breathing exercises, ergonomic sitting suggestions, and the compiled tip sheets.
We did a pre to post program analysis of participant growth and learning over the course of Unlimited Wellness. All of our participants were adults with upper limb absence. A few participants had bilateral upper limb absence. We were not able to recruit parents of children with upper limb absence. 9 individuals provided consent to participate in the program and filled out the pre-program survey. A total of 4 participants completed the post-program survey. Of the 17 Likert scaled items, 10 items reflected positive changes, with the greatest positive percent change found in participants' ability to access resources and participant learning of preventative strategies to reduce overuse conditions. Responses on 7 items reflected negative changes. 100% of participants reported that they would attend another Unlimited Wellness session. Table 1 shows our participant self-reported outcomes. Of notable mention, 75% reported that they learned how to prevent secondary health conditions and learned about others' experiences. 50% reported that the program helped them to connect to others with upper limb absence. There were inherent limitations to our study, influencing our interpretation of data. For example, We used newly designed survey tools that were not tested prior to administration. Therefore, these surveys were lacking in reliability and validity. If this program is expanded in the future, we would recommend the use of standardized assessment tools to measure program effectiveness. We would also recommend increasing the sample size, lengthening study duration, and administering one-on-one interviews with participants. We feel that these changes will produce results that can be generalized to the greater upper limb absence population.
Overall, the results of the Unlimited Wellness Program suggest that it is effective in connecting individuals of varying ages, levels of upper limb absence, and of different etiologies. As part of our discussion, we developed a SWOT analysis describing the strengths, weaknesses, opportunities, and threats of the Unlimited Wellness Program as a whole. The purpose behind this was to help educate future students and even professionals who are aiming to run a similar program. In our SWOT analysis, some examples of strengths include increased access to resources and an intimate group size. Weaknesses included differing needs between participants who had unilateral versus bilateral upper limb absence and contradictory data. Opportunities included interprofessional collaboration, and we were able to connect group participants on a national scale. Finally, threats included varying time zones and IRB limitations. What we learned in this project are skills related to interprofessional practice, collaboration, leadership, advocacy, and reflection. As a group, we have learned to endure change and understand that the needs of our patients aren't always black and white. As future occupational therapy practitioners, we hope to take what we have learned from this project and apply it across all different practice settings so that others can learn from our experiences.